entitled The Medicine of Tomorrow, an electronic talk on health informatics and e-medicine. So we're here graced by Dr. Raymond Uy via Google Hangouts to talk about health informatics and e-medicine and how it's going to affect um, potentially the Philippine healthcare system. So before that, I'd like to hand over the mic to Tim, who's gonna be here to talk to you about more about Think Tank and what we do.
Okay, so guys, thank you for joining. Uh, as you napanood sa video kanina, Think Tank is all about healthcare innovation. So we are doing this formation sessions talk as you all know that with Think Tank, the primary currency is ideas. So we want different venues of ideas so that you can form your own ideas and share them with us and yeah, great ideas happen when they have sex and when you share ideas with other people. So without further ado, I'll give um, the stage to Dr. Raymond. Okay.
Oh.
Hi, Dr. Raymond, we're live.
Hi, good afternoon, everyone. How's the Philippines? Hot, rainy, stormy? Okay. Oh, raining. Oh, it's the same. It's raining here also. Right. Thank you very much to Think Tank ASMPH, to ASMPH for hosting the event. Timothy, of course, uh, and all of the members who are participating right now. I'd like to acknowledge the presence of Dr. Lakindanum, PD resident, Dr. Rivera, Dr. Ramos, psychiatry and ortho residents in the medical city who are joining us today. And hopefully more will join. And of course, you guys, the members. So yeah, without further ado, let's begin. So this is our topic for today. We're gonna try to make this as interactive as we can. So what in the world is health informatics anyway? And how is it relevant to modern medical practice? So when you look at this guy, who do you see? The first thing that comes into mind is myself. Uh, this is during, I don't know, most of the medical school life. But this is more prominent during the clerkship and internship years, where you would go on duty and then go home and you have some paperwork to do. And this is more of a difficult thing to do here in the United States, is because most of the paperwork done here uh, is completely written by the physicians and not by secretaries who you can hire easily back home in the Philippines. So this is a huge problem right now. In the Philippines, there's too many patients, but physicians have too little time. Uh, so when we start practicing, physicians get paid per patient. So mas marami, mas maganda. The more patients you have, the more money you will get. But the problem is you're not delivering the best healthcare service you can give to the patient. And on average, here in the United States, uh, doctors average 8 to 15 minutes per patient. Do you think that's enough? You'll never know. Uh, Primary care physicians spend an average of 13 to 20 minutes per patient. So your primary care physicians could be your internal medicine, pedia, family medicine, ganyan. And then after doing your outpatient clinic, where you will want to get as many patients as you want, so 500 pesos a pop, for example, you have to do your hospital rotations or hospital rounds. And if you're a doctor in a hospital where there's no residency training program, you have to do everything. Thankfully, in the Philippines, there's so much labor force that there's so many residents, so there's no problem. But then again, it's the problem of the residents. Residents writing so many charts, so many notes, and so many things, and at the end of the day, it gets really tiring. There's more paperwork to do and less time to see patients and to deliver healthcare. So, care informatics, I guess, is just the application of informatics technologies or IT in healthcare delivery and access. But that's basically it. But it goes more than that. There's more to it than that. One of the most palpable things that you can think of during when you talk about health informatics would be electronic health records. So, what is this? This is just basically going paperless. Uh, in our day and age, especially our generation, I don't know how many of you can touch type. I bet most can touch type. Uh, I prefer typing to writing, and I can probably write paragraphs and paragraphs um, of notes in the laptop as opposed to just writing it down. Think about it this way: when you're doing your transcripts, when there's a lecture, you have a laptop out and you're typing all the notes and the PowerPoints and what the hell the doctor is saying or the lecturer is saying. So that's electronic health records. And what does this mean? If you have your health data in electronic format, for example, and you have it here in the Philippines, you have paper-based health information. So your health data is in paper. You go to the United States, you get into an accident. The only ID that you have is an ID card with your address or probably a health insurance card. You're unconscious and you're not with anyone. How in the world would they know that you have an allergy to penicillin, an allergy to something? They'll never know. So they'll try to contact the Philippines for your data, but they have it in paper form and they have to fax it, and it's so slow. But with electronic, if they digitize or if you had electronic records, you have a digital format of your health record in the Philippines, that's very easy. That's called interoperability. Your healthcare data is interoperable or will work anywhere in the world. What else can we do? When you reach third year of residency, you have to do your research paper. Well, actually now during um, medical training, you have a research paper. And usually you have to collect data. Residents don't have time for that, but they have to do it. So they go to the record section. They have to go to the record section of, for example, Medical City and gather piles and piles of um, patient records. And you have all these inclusion and exclusion criteria. So you have, for example, a pile of 100 patients, and it really stacks up. But but not all of them would be included in your research paper. So you have to throw them away, and you're wasting your time. But if everything is digital, everything is electronic, you can just filter everything out. If you want all diabetic patients in the medical city, you just put diabetes, and there you go. You have a list. And then you can do your statistical analysis with it easily, simply, and that's it. And this is one of the bigger reasons why research isn't picking up in the Philippines. It's because it's a hassle. Nobody wants to go through piles of paperwork, and that's why it's a very unattractive um, work or career to go to research. But here in the US, it's very easy and very simple. And patient education, for example, this webinar is actually distance learning is what we call it, and much, much more. So there are a lot of sub-disciplines of health informatics. What we can do in the Philippines, and this is a business proposal, is to use the untapped nurses that are working at call centers, turn them into nursing informatics professionals, and they can do a lot of things for you. They can do coding and stuff. At least it's healthcare related, so that's a good business plan. Clinical informatics would be the use of examining the use of tablets, mobile devices, and other stuff for the clinics to see if they help in delivering better patient care. Public health informatics, I think that speaks for itself. You do big data analytics. You get big cohorts and analyze them. Uh, Pharma informatics. Here's something interesting and very relevant. Consumer informatics. Consumer informatics. If you're following Apple or Google or whatever, they're releasing a lot of wearable technologies, and most of this measure heart rate, respiratory rate, number of steps taken, blah blah blah. So if anyone here has a Fitbit, it's something like that. Those are wearable technologies, and that's in the hands of the consumer. Bioinformatics, this is about genome sequencing and doing big data analytics to see whether or not some genes code for these specific diseases, blah, 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 and all these other subdisciplines. All right, so um, if you're like me, who just got really sort of forced into medicine, uh, I really wanted to go into IT before, but apparently being a physician is more appealing to parents. But trying to get out of it, you thankfully I found health informatics. And if you're thinking there's going to be no jobs for health informatics professionals, well, think again. Here in the United States, 50,000 health informatics workers will be needed in the next decade or so. And yeah, if you really want to know the environment here for health informatics specialists, there's a lot of money and there's a lot of vacancies. And if you're thinking of immigrating here, they will host your visa for you, I promise, because there is a lack of health IT professionals. Paano pa sa Pilipinas? So what can it do for you? Informed decision making. So in the bedside, you have a tablet and you're using it to look at your patient's charts and to see other probably relevant data for your patient. Remote consultations, I think this is very relevant for radiology. Um, you wouldn't want to go to the office just to look at slides, radio slides, X-ray, CT scans. Why not work at home? You can read your X-rays at home. Or if you're a pathologist, read your pathology slides at home and write your impressions. That's it. And this is also very relevant in the rural settings where uh, malayo pa ang ita-travel ng patient to get to you, but they have internet. So why not do teleconsultations? Real-time wireless sensors and devices. This would be you don't have to enter the values on the computer. Using the device automatically puts it in the data or in the computer or in the patient record. This could be thermometers, sfigs, things with motion, with video and audio stats. So just imagine the possibilities. So these are all called wearable technologies. Access to patient medical histories. Um, so if you're a consultant already and you want to know the status of your patient, you have to call the resident. So I think there's no need for that. But if you're in a hospital without a resident, then that's a big problem. And here in the United States, there are a lot of hospitals without residents. The consultants do everything by themselves. And they can access their patients' data on their phones and their PCs at home. Securely, of course. Why not? Why aren't we doing it here in the Philippines? No idea. I guess why. That's why we're doing this. Uh, Access to healthcare in rural remote settings is pretty obvious. Medical training, education, and distance learning. So this is actually so in the picture you're looking at the surgery, and these are on the people on the left are the students, so they're checking it out. Admin efficiency and care coordination. So no more calling on the phone just to tell your referral to another endocrinologist or cardio that your patient is this and like that. You can just send them the referral electronically. So you can do it that way. We're now in the cyberspace era where we have the internet. People can meet online. You don't have to be physically present to discuss a patient, right? So it's still not happening right now, and hopefully we can do this in the future. Mobile health applications. So the people who are doing their calorie counting, that's kind of mHealth. That's mobile health right there. I want to show you this application. It's called Seizure Diaries. So for aspiring neurologists out there, one particular thing you have to do when you see someone having a seizure is to record it on video and show it to the neurologist. That's to see for the neurologist to see what the seizure is and to diagnose it better. But when the patient goes home and is taking all these drugs, anti-seizure drugs, they have to document it on paper. And this application and website, actually, patients with epilepsy and seizure disorders can log when they're having seizures or when they're taking their drugs or if they're taking their drugs. Remote monitoring for preventive care. One of the big reasons for increased mortality for elderly patients around the world are falls. Nahulog. Ganyan. Uh, for example, my grandmother, she fell on in the restroom and then she hit her head. So that's it. So remote monitoring for preventive care. Um, these geriatric patients, they have these wristbands or they have these necklaces that when they fall, it automatically calls someone or calls an ambulance because they fell and they stayed on the floor for 10 seconds to a minute. They're probably unconscious, so it automatically calls an ambulance to pick them up. Uh, Obviously, efficiency, convenience, and cost effectiveness. So that's it. So we're gonna start talking about the electronic health records. Uh, so let's save the questions for later. We have a lot of questions. You can ask whatever you want, even if it's unrelated to the topic. Uh, so to satisfy electronic health records here in the United States, you have to have a bunch of functionalities and data that has to be in the software. For example, demographics, problem lists, medication lists, allergies, all these things should be there in the software. In the United States, they did a survey how many doctors or clinicians are using electronic health records, and about 74% are already using partial or complete electronic health record systems. The bigger question here is, what about Filipino doctors? How many of them are using electronic health records? Uh, I don't want to give a number, but I'm sure it's a very, very small number. There's been a lot of papers in the advantages of electronic health records implementation, efficiency, return of investment, cost savings, e-prescribing, faster and more accurate billing, and all these things. Uh, Physicians here, they spend on average 4 to 9 hours per week on paperwork and administration. This is not charting, mind you. These are other things, other paperwork that can be automated by electronic health record systems. So, physicians and electronic health records. There's a lot of discussion and controversy in this topic. And the funny thing about this is the older the doctor, the more hate they have for electronic health records. And I think you would kind of know why. Older doctors, they didn't grow up in an era where laptops and desktop computers were everywhere. So in this study, what they saw was the fewer years since medical school completion, the higher the use of electronic health records. So higher satisfaction, higher adaptation rate, uh, and all these things. And doctors who are fewer years in practice or are young physicians favor electronic records more than the older physicians. And here in the US, a lot of physicians are retiring. So those physicians who are at their 50s are retiring at 50 because they don't know how to use the electronic health record systems. So they just retire, they just give up. A quick history of electronic health records here in the U.S. is it started with Bush. He wanted EHR or electronic health records available to most, if not all, Americans within the next decade. So it started 2004, and now it's a decade next. So we're about to reach that, but we're about 75%. Ah, oh, I mean, sorry. Marami nang na-enroll in the Obamacare or the Affordable Care Act. But then Obama, again, called for the National Electronic Health Record System now. So everybody is enrolled. Well, most are enrolled. And since then, starting 2006, you can see a trend going up. Uh, the one in pink is any electronic medical record systems, and the ones in blue are probably just doing Excel sheets or Microsoft Word or something like that. But as you can see, the adoption rate is growing, and that's because they're getting reimbursed for using electronic health record systems. Are patients satisfied with electronic health records? There's a discussion here wherein the art of medicine is disappearing because doctors are using laptops as opposed to touching the patient. Well, you think about it this way, the laptop is just like the piece of paper that you write your clinical data in. It's just the same. It's just the way of interviewing and integrating the laptop or the whatever you use to input the data into the clinical interview. And there's very high satisfaction rating. Patients actually think that you're smarter and more techy because you're using a PC in front of them and giving them adequate healthcare using the newest technologies. So this is the more exciting part, is especially for new physicians and especially you trainees because ASMPH has a big plan for you guys. There are open source or free EHR software available to you right now. So there are three things. There's Open MRS, Open EHR, and Practice Fusion, which is a cloud-based service. This is Open MRS. MRS stands for Medical Record System. Excuse me. And looks like this. It's free, mind you, and I'll show you a live demo in a minute. If you check out the image in the lower right, you can see that they actually graph the blood pressure patterns of patients who were enrolled in the medical record system. And yeah, we're gonna go on live demo right now. Is everyone okay? Everyone still alive? Okay, exciting na to. Promise. All right. So, open MRS. This is it. This is the login screen. But before the login, I want to show you guys the website. So this is OpenMRS. We actually have a community here in the Philippines for this, but I'm not sure where in the world they are right now or if they're actually rolling out OpenMRS. But it's as simple as downloading a zip file. Okay, go to download. You can get the standalone package, which is operating system agnostic, which means it will run in your Mac, on your PC, on your Linux computer, or whatever. You unzip it and you run it. That's it. No other hanky panky. And then you will get this one, a login screen. So first, usernames. You can actually have doctors, nurses, and clerks have usernames and passwords, and the level of access that they have relates to the role that they have. So in this case, let's do a demo. I am a doctor. So I made this username doctor. Uh, and then you can select the location for the session. So if you're in the outpatient clinic, the laboratory, or you're a clerk in the registration desk, or you're in the inpatient ward, it knows where you are. So welcome. I'm now logged in as Jake Smith, which is a doctor at the outpatient clinic. Okay, we're gonna register a patient right now. So you just click on register patient and it asks you a few things. Uh, what's avoided here is mouse clicks. You can just do tab browsing. So given, let's say his first name is YL, TMC intern, right? Family name is uh, Pedro or something. Sige, Ateneo na lang. And then just press enter, male, female, let's say male, birthday, uh, that address, let's just put Philippines. Everything here is customizable to your liking. So if you don't like how it looks or you want more information, you can customize it easily. Then there you go. We just made a patient and this is his dashboard screen. So it's a very clean interface as opposed to the other open source solutions right now. And what we're going to do now is we're going to start a visit. So we're going to start the encounter right now. Yes. And here it is. The first thing you do when you see a patient, for example, I'm a nurse who's logged in. So the clerk registers the patient first, like what we did, and then it passes on to the nurse who captures the vital signs. So there's a capture vital signs action here, which will prompt this page. So height, let's say 170 centimeters. This is customizable. You can put this in inches. Weight, I guess 60 kilograms, 70, I guess. And then gives you the BMI. Temperature, 36.7. Pulse rate, 60 beats per minute. Respiratory, 20. Blood pressure, 125 over 70, for example. And blood oxygen saturation, I'm assuming 100. And then you just press enter, and that's it. And you can see all the vital signs here in the dashboard, right here. It's that easy, that easy. All right, and there are two ways of doing a visit. One is called the visit note. So again, you put your provider name, the location, and your diagnosis. So this is highly customizable, uh, and we can customize this for ASMPH, and we can copy the Ateneo format or the Medical City format or whatever format you want. Let's say TMC intern is suffering from knee pain. Knee pain. So I think the diagnosis is... Oh, wait, sige, iba na lang. Tension headache. Or a different headache. So that's coded already. And this is using the ICD-10 code. ICD stands for International Classification of Diseases. It's the standard for coding diseases and for billing diseases around the world. We can put a secondary disease like hypertension. And then you have essential and secondary hypertension. It's up to you. And then here is the clinical note where you will put your history and HPI and everything. So the problem here is it's all free text, right? And that's good and bad at the same time. So hello, uh, a few hours prior, intern was overworked, and started to complain of headache. That's it. So you save it. Then it's right here. You can see the diagnosis here: essential hypertension and headache. And then you can look at the visit note here. You click today, and then you can see the visit note here. And then you can see the text here. But that's very limited, right? So there's another way of inputting data, which is called form entry. So I created an ASMPH initial encounter form as a demo. This took me about an hour, 2 hours to do. So this is what the form looks like. Mind you, I am not a very creative person. All right, so location. We're at the ward, for example, the inpatient ward, and I'm Jake Smith, and my chief complaint is knee pain. And as you can see, it auto-populates. So if my chief complaint is abdominal pain, just wait a few seconds. So you get a big selection of abdominal pain. So what about chief complaint? Acute abdominal pain. And you can write your history, blah, blah, blah. Allergic to peanuts with a anaphylactic reaction with a free text comment. Hello, Kitty, for example. Past medical history, osteoporosis of the knee, osteoarthritis of the knee. Are the symptoms present? No. Date of diagnosis and free text comment. And you can add more things here. So if the patient has a lot of problems, you can just keep on adding and you can delete if you don't want it. Procedure, appendectomy, for example, it was done, I don't know, 2009, and the outcome is satisfactory. You have a comment here. Smoker, Yeah, yes, from too much stress, alcohol, currently, obviously, and probably in the past. Then there you go. Then you submit that. Let's remove this. Then submit. Yeah, just a bunch of things. But there you go. And that's just about 2 hours of work. And all the graphics here you can customize. You can customize the colors. If you don't like the teal, you can make it pink or red or blue, Ateneo blue, or LaSalle green if you want. And that's it. That's OpenMRS in a nutshell. And what we're planning right now is we want to give the software to all the students. Of course, we're gonna fix it. We're gonna make sure it's perfect. Give it to first year, second year, third year students, and we will spoil you. We will give you a nice electronic health record system that you don't want to go back to paper-based systems anymore. And that's our way of trying to leverage electronic health records in the Philippines, is by starting from the roots, starting from the trainees. Uh, okay, so any questions about OpenMRS? Uh, okay. All right. Uh, let's continue. I bet this is interesting for the clinicians who are the residents especially, or those who are doing clinics or moonlighting. Let's see. All right. Let's continue with the presentation. Let me do the screen share first. Okay. Where is it? Okay. There it is. All right. So, more things. There's an application called PubMed for handhelds. For those who don't know what PubMed is, it's the Google of um, medical research. So if you want to know the latest about the management of diabetes or hypertension, you go to PubMed and look at the articles there and the published journals. And this is an application where you can just uh, it asks for a few information, like bare minimum information, and you can get a lot of things from here. One is Pico search, PICO. You just put a condition, for example, diabetes, an intervention, probably metformin, compared to another drug, and you want to see the outcome. So it gives you all the latest publications related to that condition and that drug. Another thing is Ask Medline. So if you have a patient, or if you yourself has a free text question like, hmm, does chia seeds decrease help in weight loss, for example? You can see it here. You just submit it in free text and gives you a bunch of journal articles that link to chia seeds and weight loss. So shout out again to Project Aries, a project of Think Tank. Uh, I showed this off in the National Library of Medicine, and they said this is really, really good, especially uh, with the state of research in developing countries and how people there's no indexing here in the Philippines. So there's so many research coming out of residents before they graduate, but after presenting the research, it just stays in their hard drive like nothing. There's nothing afterwards. They're just happy they did their research, they passed their third year, and then they move on. That's it. Nobody benefits from that. Nobody benefits from research put in the shelf or put in the hard drive. It has to be indexed so people can see. So that's yeah. So good luck. I hope this project pulls through. What is the Philippines doing right now? There's currently a partnership between the WHO, the DOST, and yes, the DOH. We have the National E-Health Strategic Toolkit, and they made a vision and action plan, and they did a few documentations on how they would monitor and evaluate the rolling out of e-health in the Philippines. Developmental framework. It was started by Dr. Ona and all the bunch of other people. Mind you, none of these people on top in the steering committee. Most of them are not health informatics professionals. The ones in the working group, the TWG. Sorry, that's not the T star. TWG stands for working group. I think I'm not sure which one of them are health informatics professionals or do have the credentials for it, but I'm sure some of them do. But do we need more? There's a roadmap, starting from leadership all the way up to evaluation and sana nga masunod ito. There's the AHIN network, which hosts a webinar every Monday and Friday, which talks about different health informatics topics in the Southeast Asia and the Asian region, not just the Philippines. This is the one in the middle is Dr. Alvin Marcelo. He's probably the pioneer of health informatics in the Philippines. Uh, and he started a Philippine Medical Informatics Society. So there's something like that. There's a society for medical informatics. So anong problema sa Pilipinas? What's happening? We have these so many things. There's so many implementations. There's so many prototypes. But what's wrong with us? What's wrong? The pilots show that they're very feasible. They show very good results. Magandang implementation, magandang results. But what's happening is there's no sustainability and it doesn't scale up. Sustainability meaning people who are implementing the prototypes don't have a business plan. They don't have a way of maintaining the funding and making sure that the program continues on after they leave. And scalability. Uh, an example of this would be in the sub-Saharan countries like Uganda and Rwanda. They distributed OpenMRS as a prototype for community health workers there and rural health centers. And then they had really, really good results. And then the people in the higher ups saw that it was working. So they turned it into a national policy. And the people in Uganda and Rwanda, all the doctors there are using OpenMRS. So they scaled properly because they created a sustainable uh, timeline or something. So that's it. It's too wordy. Let's skip that. So yeah, so Philippines, let's try to fix ourselves. So digital pathology, this is another aspect of health informatics. This is actually done in the University of the Philippines, in the National Telehealth Center. What they did was instead of giving the slides and letting students look at it in the microscope, why not have the slide digitized in real time, and everybody can see the slides and everybody can interact. And they can see the slides not just in their computers, but they can access it in their iPads, in their tablets, and their mobile phones. And yeah, they saw it was very effective. So, information seeking trends of professionals here in the Philippines. Again, this is a study done here in the Philippines, which originate again. mm, excuse me. Uh, in the study, we saw that 88% of physicians encountered at least one clinical question daily, which means most physicians, when they see a patient or a bunch of patients, they have a question. There's there's something in their management or in their diagnosis that they think is lacking. So that's a clinical question. But look at the percentage in the bottom right. Only 58% of doctors were likely to search for answers. And what's the problem with that? So I think, for example, when I see a patient, I I'm not sure if I'm getting the right diagnosis or giving the correct medication. So I call someone and then ask them what I should do. But sometimes there's too many patients and there's no time to call anyone. And the bigger problem here is there's these doctors, these residents, they don't have access to information. I mean, they don't have internet. They're not being provided internet in their hospital and stuff like that. Even in the medical city, they don't give you the password to the internet. I mean, residents, I don't think they have access to uh, internet while they're doing their rounds. They have to use their personal subscriptions to 3G, 4G, or whatever. Uh, so most have internet at home, and only under half of doctors have internet at work. Um, for medication questions, they usually refer to formularies, and colleagues were the first line They're a first person that they call when they have a diagnostic dilemma. Look at this. This is evidence-based medicine practice among internal medicine residents in a community hospital. This was done in 2007. That's why it's a palm trio. That's the thing during that period. And they saw that real-time access to medical literature may be achieved through smartphones, especially now. Our phones are very, very powerful, and they make EBM practice very easy. Here's another way of here's another health informatics solution for you. Instead of accessing all these information via a web browser, in Botswana, another sub-Saharan country, they do SMS or texting, where they would text their question in a number and then they would get results or clinical guidelines for the results from their question. Okay, so this is comparing clinical decisions based on full text or abstracts. So here's the thing. It's people think it's hard to practice evidence-based medicine because they have to read the whole article or the whole research paper just to know what to do. But from a lot of papers that's out, simply reading the abstract already helps significantly and increases clinical decision accuracy. So again, providing access to these journals at the point of care or when you're actually delivering healthcare to patients, it's very important. This is my study, which examines confidence and information access in clinical decision making. Here's the thing: uh, when a doctor sees a patient, he thinks he knows everything. Uh, he thinks he won't make a mistake. So they're pretty confident that they're giving the right medication or doing the right diagnostics or diagnosis. But when you look at the contingency table in the middle, only 17% of my total sample population who were confident they didn't need any other information were correct. Only 17% were correct, and the rest is incorrect. Like 12% of them were confident but were wrong. So they were indeed overconfident that tama sila pero mali naman pala yung decision nila. Thankfully, more doctors are diffident. Diffident meaning they're not confident, which means there's too much to learn in medicine that you won't know everything. And true enough, they're not confident. They are indeed incorrect at 43%. So if you think you don't know the answer, there's a 43% chance that there's about a 43% chance that you'll be wrong. And then it is these misalignments in confidence and clinical decisions that can affect the correct healthcare delivery to patients. And again, reiterating the point that we have to provide access to physicians, provide internet access to physicians so that they can do online searches. Uh, hmm. So should we invest in health IT? Well, heck yeah, we should. Because here in the Philippines, it's every year the amount of money they're investing in healthcare companies, especially IT companies who are doing electronic health records and the works, are increasing. So I want to open the talk to anybody who has any questions right now or any clarifications about anything like OpenMRS or what the hell am I doing here or what kind of research we can do together. So Timothy. Oh, oh, okay. Questions and answers. Hello. Oh, okay. Jenny. Yep. Yep.
So I went to an observership in the United States, and they were using electronic health records. And I guess my question would be, is there like studies on how long it would take for the health records to know? And
Oh.
My question is in relation to your interaction time with the patient. Because is there like a training for you to do
Mhm. Okay, so the audio is a little difficult. Can anyone Can you type the question in the group chat, or anyone there in the auditorium um, say it in front of the mic?
I'm sorry.
Sorry.
Hey, Tim.
Hello, the mic's is
Sorry. Hello.
hello, can you hear?
Oh, there. Yeah, Angel.
You hear this mic better?
Mm, talk na lang next to the laptop, Timothy's laptop.
Sorry.
Okay, can you hear me?
Yes, yes, perfect.
Okay. My question is actually about the electronic health record,
Mhm.
because when I had gone to my observership in the United States and was
Mhm.
using the record itself, I just noticed that the doctors do spend more time on the computer than actually talking to patients. And my
Mhm.
question was this: is there research or is there like an actual time that is required to use the health record, or is there training for you to use it more efficiently?
That's a very good question. Thank you, Angel, for that question. Here's the thing. Uh, EHR companies in the United States, uh, most of the people there or the employees there are computer programmers. They're not doctors, mind you. They are uh, PhD in computer science. None of them are MDs. None of them are in the clinics. They would have probably like one or two in the top that are doctors. But the forms or the electronic health records, all the programming is done by the computer engineers, or oh sorry, the programmers. And right now, they design the EHRs according to what the computer programmer thinks is correct. And that's the thing. If you know any programmer in real life, they care about the code. They care about their software code. They care about memory leaks. They care about those things. They don't care about how easy it is to use the electronic health record. And that's what we're trying to do. We're trying to liaison between the computer programmer and the doctor. Usually, end users, especially doctors who actually use the electronic medical record, are not consulted. They they they're consulted one time, and then that's it. They don't test it. They don't beta test it. They don't do time and motion studies for it. They just roll it out. That's it. That's the same way for Epic and Cerner Medical and all the other big EHR companies in the United States. Even if they're rolled out in big hospitals, doctors are complaining because the forms are not done properly. There are too many fields and there's too many mouse clicks to be done. So they did not uh, tweak the forms, or they didn't make the forms uh, compatible with how you do a clinical interview, like sa Bates. How do we do clinical interview in Bates? How do you do clinical interview here in the ASMPH or in Medical City? They never took that into account. They never did take that into account. That's why we have a software right now that's clunky to use. The form entry is very difficult, and that's why it's costing a lot of time for doctors. But for the younger physicians who are using electronic medical records and they customize it for them, they're enjoying it because it's fast, it's quick, and yeah. Oh, but that's a good question, Angel, and it's a good thing that you were able to use one personally in your observership in the States. And that is the big problem, isn't it? And the old doctors, of course, can't touch type or are not very good using keyboards and mouse. So, yep. So Jer, you have a question? Hello, Jer.
Yes, I have a question. Uh,
Actually, orient ko lang yung mga nandito sa audience natin. Raymond was talking about a lot of about EHRs and stuff like that. For those who haven't gone through um, the clinical years, let me give you a picture of why this is very important. We'd like to welcome Dr. Angel D. I'm sorry, Dr. Bisnar, Dr. Regalado, and Dr. Saniel. Thank you for joining us. So we're glad to have you. So a brief context on why Raymond and I and Think Tank thinks EHRs and health IT in general is very important. First of all, as was mentioned, there's a lot of paperwork involved in medicine. Why is this necessary? Because you want to document all that you've done. You want to trace what happens to the patient. Because in a service-oriented industry like medicine, the information on what you've done to the patient isn't readily seen. Kung in-inject mo yan ng gamot, ano yung gamot? Hanggat hindi sinulat yon sa papel na record, hindi mo alam. Pag tinanong mo yung pasyente, hindi rin niya alam kasi hindi rin siya used sa mga name ng gamot. So, imagine if you have a patient who's been in the hospital for at least 3 months, you have 2-inch worth of paperwork to go through. Eh gusto ko mong malaman, nung dumating siya dito, ano yung binigay niyong gamot? Baka yun yung dahilan kung ba't siya nag-allergic attack or whatever. You'd have to go through piles of papers for that. But if you have paperwork, it becomes streamlined. That's the micro perspective. From the macro perspective, you have the potential of gathering what we call big data. You can make cohort studies in the blink of an eye. So marami kang makukuha. Tapos dito, to anybody in the academy, ang laging problema na excuse natin, we don't have local data. Well, if we do this, we will have that local data in a click or a press of the button. So we want to give that power, that ability to the students in ASMP. That's why we were doing the Open MRS. Aside from that, we want also students to have what we call a portfolio. Gusto namin, kung yung mga pasyente nyo na tinignan nyo nung first year, may record pa rin kayo ng pasyente nyo yun pagdating nyo ng whenever. Tapos, pag nagpa-practice na kayo, may sarili kayong software na pwede nyo lagay sa office. Anyway, yun. So, are there any questions, applications, ideas? We're very open to them. Ito, si Tim.
Oh, you summarized it perfectly, Jer. It's just as Jer said. Exactly like he said. And we're gonna be the first medical school who would do something like this. Who would actually give EHR software to trainees. So yeah.
Question, Doc. How
Yep.
about security? Does
Security?
how does EHR address security? As you all know, recently in the news there has been a lot of hacking, and what are the steps that we could do to ensure our patient confidentiality?
Okay, let's start from the top. Here in the United States, we have the HIPAA, HIPPA, which is their basically their law saying that patient data should be secure. When you do data analysis, patient data should be de-identified, meaning the name is not there, the birthday is not there, there's no identifying data there except age and pertinent clinical information. So when we're talking about security in the electronic health records, think about it this way. Computers in the OpenMRS, your patient database is stored securely, or I mean, it's stored locally in your drive. But if you deploy a server which hosts the OpenMRS server, all the data is in that server, so it can be in Ateneo or wherever. You know, when you think about it, think about security. When you compare a file that's printed in your office versus something that's in a hard drive or in the cloud, which is easier for a thief to get? I mean, we're all paranoid about hackers hacking into digital systems on the internet, but if you're deploying a very, very small, your personal health record system or a small health record system, hackers won't really attack you. If you become big, of course, you'll have all the firewalls and all the encryption you need for your data. So that's the part of health information security. There are protocols in health information in the data that encrypts your files and encrypts patient data that they can't be accessed by anyone who's just using your laptop. For example, I have OpenMRS installed in my laptop. Nanakaw siya. Somebody stole my laptop. Do you think they'll be able to access the patient database, all my patient portfolio? No, they can't because they don't have the username and password to access it, and so forth. Nobody will do identity theft in the Philippines yet because we're not in that level yet. We may have we can put good laws and policies for it, but the first things first, we have to increase awareness for electronic health record systems. But yes, security is important, so that's a good question.
Dr. Uy, we have a question from Dr. Lakindanong over
Mm-hmm.
there in TMC.
Mm-hmm.
Nandito sa chat box. Question. We're trying to start using TMC Prime, which is the EHR that was the prototype EHR for Medical City in the outpatient department of the Medical City. But the common complaint is that the internet connection is always lagging and it's not available outside the outpatient department. So it's becoming more of a burden. So will it be futile to use EHR if the connection that we're using is still far behind?
Okay, that's a very good question. Uh, I personally know the project manager and the head who created TMC Prime. After it got rolled out, um, there's a big problem with the amount of money that's being invested by TMC. This is an opinion, okay? Not much is being invested in health informatics in hospitals around the Philippines, which means health informatics professionals are not being paid enough. So they left. And right now, I don't know who's doing the project management for TMC Prime, but yeah, that's the big problem. I'm not sure if you guys still have support for TMC Prime back there. The internet connection is always lagging. That's a infrastructure problem. Uh, so will TMC upgrade their network? What's the network anyway? And are you using Wi-Fi to access the TMC Prime? That's a very big question. If it's lagging, then that's a problem of your another department in Medical City. Yes, that's
No, I
correct.
just
Yeah. The investment is too small. That's why we're trying to invite Eugene Ramos to this talk to tell them that they need to invest in data. They need to invest in healthcare informatics because there's money in it, and that's what we're trying to assert. Uh, so that's the problem. I mean, uh, TMC Prime. So the connection, if it's a connection problem, it might be a hardware problem, and you guys should talk to the department who's doing the hardware, not the software side. Yeah. So I'm sorry about your experience with an EHR. Unfortunately, it's negative right now, but we'll try to correct it. We're gonna try to give you open MRS, so you can, when you're finished with residency, you can use that in your own clinics. So, yeah. Right.
okay.
Thank you.
So transcribe ko yung sagot ni Dr. Raymond. So anybody has any questions, any ideas? Kasi ako, share ko lang, off the top of my head, imagine nyo lang kung lahat ng rural health clinics sa Pilipinas at mga hospital natin, merong capability na ganito. Imagine any of our patients can just go anywhere and they would have no problems with registration, sa pagsusulat ng information kasi nandun na. Tapos hindi ka na magkakaroon ng problema na pag galing kang Mindanao tapos pupunta kang Manila, uulitin lahat kasi ma-access mo yung data. Kasi a big part of the practical applications of EHR is it maximizes the resources already used. Ang popular dito sa Pilipinas ay paulit-ulit tayong gumagawa ng mga laboratorio, lalo na pag baseline. I'm not criticizing anybody, but this is a common practice that, for example, in the same day, I was in, let's say, St. Luke's, kunyari lang, nagpa-CBC ako. Then lumipat ako at another institution. Tapos sabi nila, pa-CBC ka ulit kasi wala yung record namin. So they don't take your word for it na ito yung results ng CBC. So, but if you could access that and it's uniform, wala nang problema. You could build on what has already been done. And that adds more value to patient care rather than doing redundancies, which is a waste of time and money. And in medicine, most of the time, the most valuable resource is actually
Time.
time.
Yes, time. I agree. So, when you reach your community rotations, if you go to Payatas, there's a thing you do there called kudlit. And that's basically doing a census. So think about it this way: if you enrolled everyone in the electronic health record, for example, OpenMRS, everyone is enrolled there, you can get a census report in one click. You can have a census of all diabetic patients in one click, and you can aggregate all that data and information in other areas. For example, not just Payatas, but if you roll it out in your other clinical rotations, you have a database, and you can do your research there, and you can aggregate that data and do some studies. So think about those possibilities. Some people who are bored with research might think this is very boring. I don't really care, but there's I'm telling you, there's money in data. You can actually sell this data to someone in the United States who wants to do a retrospective study on blah 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 in developing countries. Pwede na ibenta yan. Data is valuable. That's why people hate Facebook here in the United States because they collect your data and they get use that data for profit. How? Well, basta. Marami silang ginagawa. So, yun. So, like what Jer said, even residents are having the same problem. They have to do a discharge summary. By the way, OpenMRS can summarize your data in paragraphs very quickly. So you don't have to type the discharge summary. It's automated for you. Again, some people will think, oh, there's no more learning. Residents are not learning anymore. But they can learn more with interacting with patients than doing paperwork. So that's an opinion, but I'm sure it's a popular opinion. Yeah. So, anybody here in the room, coder or a computer programmer?
Please, we have a question here from one of our audience members. Please introduce yourself to us, year level.
File 6.
Uh,
Hi, I'm Justin from YL6, batch
Hi.
2018. Hi. My question is more of, you know how you were saying that you were trying to give this EHR to us so that we could
Yep.
start compiling data essentially.
Correct.
Does the EHR have any counter-checking system such that to make sure that we're actually putting in the right data? I mean, we're still students, so we're still trying to, we're still in the process of learning.
That's
We
right.
don't really have as much experience yet.
Mhm.
So what if we put the wrong data and then that will affect our patient in the long run? Like, say, if you access the patient's data
Mhm.
that I from the States,
Mhm.
wouldn't that, if there was no way of counter-checking, wouldn't that pose a really big problem in the management of that patient?
That's right.
And I also have a second question,
Mhm.
unrelated to this one. But I heard from my relatives in the States that there is this thing called Dragon Speak, which is
Yes.
basically,
Dictate.
from what
Yeah.
I understand, Dragon Speak is
Dictating.
it transcribes your audio into digitalized text.
That's right.
So is there a way of implementing that as well to the electronic health records to make HR note taking essentially faster and more efficient?
Okay. All right. Thank you for that question. Your first question, let's do one question at a time. The first question was about the data that you're putting at the OpenMRS when we actually give it to you. Uh, we'll know when you did the patient encounter. Uh, what you should do is you should compare this to your paper format. We're just replacing your ASMPH encounter form with a laptop, a laptop with information that you can access. So kapag paper-based ka lang, you need a book or you have a cell phone. You need to search e-medicine for your information on the disease that you think the patient has. Well, labas mo cellphone mo at i-browse mo while you have the paper form in front of you. But when you have the EHR in front of you and you have access to information in PubMed or anywhere, I mean, the learning is there. Andun yung learning. When you're saying that you're still students and you think that the data you're going to be inputting there won't be valuable, uh, the whole point of giving it to you is, or the whole point of giving students EHR is for them to practice the clinical interview with the laptop on the side. How do you integrate the laptop when speaking to a patient? Of course, there's this big screen blocking you. Where do you position it? Do you position it 45 degrees? Are you able to touch type? Are you making sure that everything all the data you're getting is complete? Na is the encounter still personal? I think it's valuable in that sense. Uh, uh, we can okay, some of the encounters in the lower year levels fake yung mga pasyente ninyo. Obviously, we can't harvest that data. But when you reach clerkship and internship, where you'd probably be putting real patients, you can filter those patients during your report during the time that you're getting a sample population in your database. Pwede mo lang kunin ang patients after YL7. And that's your database. Those are the real patients. That's where you can do your clinical analytics, and I think solves your answer. So don't worry about inputting bad data in your EHR. That's for practice. That's for spoiling you, so you don't want to use paper based anymore. No more bad handwriting. Nothing like that anymore. So imagine that. Question two is about Dragon Dictate. Dragon Dictate. That's another person. There's two ways of doing it. One is your basic voice recognition, and it inputs you whatever you're dictating in free text. Mahirap i-data mine ng free text. We do what we call NLP. NLP is called Natural Language Processing, where a computer scientist parses your free text and tries to categorize them in their semantic meanings. For example, the patient is a 25-year-old male who came in complaining of a headache. Itatag niya yung grammar ng sentence that tags headache as the chief complaint. So you have to get NLP guy, a natural language processing company, to analyze that data for you. All right. So that's called unstructured data. The second form of Dragon Dictate is actually a real person transcribing what you're saying. Another person is typing what they're hearing. So that's the other part of Dragon Dictate. And a lot of doctors here do the dictation. But the problem is, part of the electronic health records criteria here in the US is that specific patient information should be structured and it shouldn't be completely unstructured. So that's the problem with Dragon Dictate right now. So yeah. So the trend right now. Oh, sorry. Sorry, quick lang. The trend right now is medical scribes. There's a may malaking business proposition right now to have medical scribe companies here in the US. Medical scribes meaning the doctor doesn't input the data anymore. He has a secretary or a medical scribe to input it in their complicated EHR. If the EHR is complicated, let someone else do it for you. That's a stopgap solution. We have to have a EHR with good form flow, which mimics the clinical interview. Without tick boxes and a lot of drop boxes, everything is keyboard based and shortcut based. I hope that answers your question. So that's a very good question. So cool. Thank you.
Just to add to your question, first yung about yung counter checking. May yung EHR kasi nabibigay namin for students, may front end and back end. Meron sa side nyo, meron sa side for the faculty to check what you actually input. That's the plan. We're still going to iron it out. But this is more than just something for students to make their portfolio. This is something to make checking efficient for your faculty. So, two-way yan. Nabibuild on yung knowledge nyo at nagiging efficient yung processes ng school. So that's the vision for why we're doing this. And hopefully, we can actually start disseminating this to other schools. Kasi that's how you're going to build your user base. If you remember the story of how Microsoft started out, they gave away Windows for free. And when people already knew how to use Windows, they actually paid to buy and to use it at naging standard siya. And it was cloned and gano'n. Ang objective namin is for EHR to be more readily adopted. That's a very useful way of doing it. Very business, this is the application of your MBA, of our MBA. On the second part, yes.
Go.
On the second part, yung the Dragon Dictate, I remember a software friend of mine saying, part also of voice recognition is you have to have the SDI or something like your voice recognition database. So for us, kailangan tailor fit yan. You have to invest in research and actually recording Tagalog, the accents, and the English that we use, the accents, in order for speech recognition. So, kung nahalata niyo si Siri, may mga weird stuff siya pag tinatanong nyo, even English, kasi may accent recognition din siya.
So business proposition. Well, OpenMRS is free. It's open source. So the support is usually an online community. The you want to monetize it, then get a pharma company in it. So what's in it for them? So it's free advertising. Ilagay mo yung logo nila doon, Pfizer, GSK, whatever. They want people to use azithromycin or whatnot. They can put that in OpenMRS, and that will assure this continued support of OpenMRS in the Philippines. So that's just one small idea. Nobody's doing it right now. So that's it.
Yung other part rin ng Open MRS is actually we can incorporate e-prescription. There's actually an app in iPad na pinakita sa isang EHT conference. It's called Dr. Mata e-prescription. It's free for the iPad. You guys can get it. It's an entire formulary. Kung may hindi kayong alam na drug, lagay nyo doon. Tapos ilagay nyo siya sa kahit anong printer. Pwede nyo i-print e-prescription, pipirmahan na lang. So that's for free. That's another free one. But ayun, so let me give another anecdote. In the US, actually, in Silicon Valley, they make I read an article that people are developing about 5,000 health apps per month. That's a lot, and these are non-medical professionals. So they have the technical skills. They don't know the need. You have like yes. You have like something like MyFitnessPal. It's very useful. It's amazing. But then if you look at the App Store, the Android Store, the iStore, there are about 500 of them. They're all calorie counters. But then if you look, ang daming recipes, paano ako gagawa ng diet plan, the technical knowledge, the medical side is not there. So there has to be a meeting of the minds. That's a very big opportunity. That's why we're holding this. If my memory serves me correctly, this is actually one of the first webinars that is hosted in ASFH. So congratulations, everyone. You're making history. So
e-prescriptions, yeah.
yes.
That has to be how they do e-prescriptions here in the US. For those who have done some vacationing here, they have CVS, pharmacy, Walgreens, blah blah blah. Sila yung katumbas ng Mercury Drug and the Watsons. When a doctor prescribes the medicine to you, they don't give it to you in the clinic. They actually send the e-prescription to CVS pharmacy or to Walgreens or to the Watsons here, whatever, and then you just go into the counter and pick up your drug and pay for it. That's it. That's e-prescriptions. Wala nang sulat-sulat. All the instructions are there in the small thing, the medication pill box that they give you. That's it. Everything's there. So that's e-prescriptions.
Okay. So other add-on to that. Kaya importante e-prescription is ano ba yun, Raymond? Was it 40%? 40% of all medication errors are because of bad handwriting. We're not kidding.
Yeah.
People have died. There are actually statistics like 25% of all patients with fatal medication errors are due to bad handwriting. That's how bad it is. May anecdote yung isang presenter dun sa EHT conference na meron isang prescription parang kinalmutan ng pusa o ng manok. Tapos nabasa siya ng senior na pharmacist. Hindi nila alam kung paano niya binasa, pero parang paracetamol siya. Tapos may picture siya doon eh. Tapos kahit ako hindi ko siya mabasa and I have bad handwriting. Okay, so those are one of the things. Just by changing prescription, you can save lives. That is a very cost-efficient way. Even more cost-efficient than, it's probably up there with hand washing. So, ayun.
I agree. There are a lot of published studies on what Jer said just right now. A lot of people die from adverse drug events because of a wrong prescription or bad handwriting. And imagine if inpatient siya or in the ICU. Imagine the problems there and the litigations. Here in the Philippines, well, probably wala naman nagde-demand masyado ng doktor dito. But in the US, if you screw up, you're gonna take a big hit. And that's the thing that kills a career.
Okay. May question ako actually for the audience. Sino na dito na hospital? As in ER or whatever? Raise your hand. Joe, di ba? Joe, can you tell me your experience about the first time you actually went to the ER? And I'm going to relate this to Dr. Uy. Oh, hindi basta yung naalala mo your console. Hindi, the process. Run us through it. What was the story? Anong ginawa sa'yo? Pagdating mo doon, sinong kinausap mo? Oh, tapos anong tinanong ng secretary sa'yo? Okay. Gaano katagal yun? The entire process, in your estimate?
From pagpasok ko sa hospital?
Yes.
2 hours.
2 hours.
2
Okay,
hours?
so 2 hours ang running time niya, Dr. Uya. Can you tell us the story of when your wife was about to give birth?
Okay, perfect. Yeah, perfect example. Um, there's in hospitals here in the US, they have something called pre-registration, where if you're coming in for a consult, you just log in a website, all your demographics and all your information, your phone number, your credit cards, are already pre-registered in their system, in their hospital system, and that's electronic medical record system or electronic EHR system. Pagdating mo dun, they don't ask you anything anymore. They know who you are. They just ask for identification, like an ID. They see your name, they see your face. Okay, you're the patient. Come in. And they know all the medical history that the patient can provide during the pre-registration time. All it took uh, from arrival in the hospital, like what, 5 minutes, and she's already seen by a doctor. And it's a busy hospital too. Ang bilis. Oh, here's another thing. Um, Bayad. We just stepped out of the hospital. Wala kaming binayaran. Why? Because they mail you your bill. And then you pay online. It's online ng bayad. Wala nang cashier. There's no cashier. Everything's paid online. Because here in the US, everybody's stuck with their SSS, your social security number. If you don't pay anything, if you don't pay what you owe, they're gonna they're gonna find you and they're gonna put a lot of itatax ka niyan and maraming penalties. It doesn't exist here in the Philippines. Ayun. So yun yung thing. Nobody cares. Kung matakasan mo hospital bill mo, edi okay. But mabilis. It's so fast because their electronic health record system here are operational. Paperwork, very minimal. Charting, everything is computer based when I ask the nurses and the doctors. Yeah, so that's the experience here. And the dream is to have the same experience here in the Philippines. So yun. Not just for the people with money, but what we want is the general public to experience the beauty of electronic health records. For example, maternal mortality. At text, di ba piso lang yan? 50 pesos, meron ka ng only text. What if you have a target demographic mo, mga mothers who were pregnant? You have to tell them not to go to a traditional healer or a hilot and see their OB. That's the primary kumbaga, solution to decreasing maternal morbidity in the Philippines and to reach the Millennium Development Goal. But, meron bang SMS system na nangyayari ngayon? Oh, wala. Sorry. It doesn't exist. Why? Because there are no partnerships with private companies like Globe and Smart who will actually subsidize a service like this. Wala. Nothing. There's nothing. That's the thing. Somebody has to start something. It has to start somewhere. Partnerships have to start somewhere. So that's the problem. Where do you start? So we start here in the university. So yeah.
For your information, Dr. Raymond we was saying something about Smart and Globe. They're actually open. Take note, ngayon pala, kung may proposal kayo at gusto nyo gumawa ng project na gano'n, at isusustain niya siya for any number of time. Globe has health, CSR, readily available. They have asked many universities, undergrad to actually make programs. And there were many pilots, but never took off the ground. Why? Kasi may disconnect. Yun nga, it's the same thing. They have the technicality, they have the resources, but they don't know what's happening on the ground. We know what's happening on the ground. It's up to us to reach out to them. This is a very big opportunity for anybody who wants to get in this type of work and to make a big change. And yun nga, from my experience in community, most of these mothers, the only reason they don't go to their local health centers is because hindi nila alam. Parang sasabihin mo, nanay, ba't hindi kayo pupunta? Ano ka, 2 years ago, taga Tacloban ako. Sa kami, ngayon lang ako napunta dito, wala akong alam. And they don't know where to get the information. Information is power. Information is crucial in this day and age. And there's a way to reach them. This is one of those ways.
So question for the audience. Any of you with computer background? Yung mga hindi bio, mga CS? Anyone? Nope. Anyone in the audience know how to program? C, C++, Java, HTML? Little bit. Yeah. Yun. So, how many years till you graduate? Kasi mag-fellowship ka dito. So I'm inviting anyone who's interested in doing a fellowship in medical informatics here in the US. Yun.
Kailangan ba ng Emily dyan, Doc Raymond?
No, you don't need Emily. And it's visa sponsoring. So they will sponsor your visa, you'll be a federal employee. And yeah, they give a good stipend also. As in, sorry sa na lang sa mga resident, pero my stipend is pretty good as a fellow. So, yep. You're treated as an equal to a PhD graduate. So it's called postdoctoral. So our MD actually counts as a doctorate program.
So any...
So the small info in this fellowship program here in Bethesda is that all the previous fellows were from UP, PGH. And we're breaking that barrier. We're involving Ateneo in partnering with the National Library of Medicine in the US. All the research I showed you were partnerships between UP and the NIH, US NIH. Bakit Ateneo? Wala. So yun. Lastly, if you want to program OpenMRS, we're actually part of the Loyola schools. So we have to reach out to their to their science and engineering branch to help us with programming. So yeah, we have to do that.
So with Dr. Ui's last statement, we're trying, my personal advocacy is more of integration. So maybe in the next couple of years, we'll be trying to integrate more with Loyola. Because a lot of undergraduate students have the skills we need, and they don't know the need. For example, sa OpenMRS lang, in EHRs in general, the biggest issue most people have is actually user interface. Kaya ayaw nilang gamitin. Mukha siyang pang techie. So kung gawin niyo siya kasing dalit ng tablet niyo, mas maraming tao gagamit sa kanya. At kung fashionable siya, naging statement siya, more people would ascribe to it. Secondly, management people. They are the people with the know-how to market, pack it, put it in people, sell it if you need to. So then you have the programmers who actually do the programming. Marami, maganda siya. As in, pag ni-unite mo yung force niya, us and everybody else, we can become a very significant force of students. And these are students changing the world. So that's what we want to do. So Dr. Raymond, any last words?
Oh, check out the screen. This is actually a module for OpenMRS for those who planning to go to pediatrics. There's an integrated growth chart module. So you don't have to chart the growth chart. You don't have to chart it in the growth chart. Lagyan mo lang yung height, weight, head circumference, whatever. Sorry sa pedia. Ayan. Head circumference, weight, length, and it will automatically plot it for you. So there's actually a module for that. And that's created by programmers, not MDs, programmers. So yeah. So hopefully we'll do something like that. Maraming pwedeng gawin sa health informatics, and hopefully we've spurned interest. There's a lot of money in health informatics right now. It's the trend for non-clinical work. So if once you experience clerkship and internship, you're gonna think to yourself, how can I get out of this? And I'm welcoming you to non-clinical work in medical informatics to fill that gap and to do research. Yeah.
Okay, so last questions, comments, meron pa ba? Kung wala na, meron? Yes.
Oh,
Me again.
oh, hey.
It's the question popped up when you were talking, when you were giving that anecdote.
Mm-hmm.
So basically, your EHR or the existence of EHR and putting that, letting the pharmacies access the records, the e-prescription, sorry.
Mm-hmm.
Wouldn't this mean that a lot of jobs on the administration side of things in the hospital will be redundant, and so they're kind of out of a job? So essentially, that's what I understood, that they are essentially out of a job. The EHRs, you're able to incentivize doctors, nurses, the ones practicing the health care, the part, medicine, the personal part of medicine. But for the administration side, they're becoming redundant. So how do you address that on the MBA side of things? What did the US actually do to, let these redundant people leave?
Sorry, can you clarify what you mean by redundant? Redundant umuulit?
Like you said earlier, there's no need for the cashier anymore.
Okay, okay. Mm-hmm.
So you don't need them. You don't need them to do their job, their original job in the hospital.
Right.
So I'm guessing they're no longer in the hospital. They're no longer working in the hospital as a cashier. So
Oh yeah, they're not. They're doing something else. They're doing the account management. They're not collecting money. They're managing the patient's account. So ganun. Tama ba? Does that answer your question?
yeah, essentially, I was trying to figure out what are you going to do with these people who, they originally had the job of, say, being a cashier, and then now they're no longer a cashier because of EHR. So how do you incentivize these people to adopt EHR as well?
Well, unfortunately, because they're cashiers, they might not have administrative power to decide on on if the EHR rolls out in the hospital and e-prescription actually blows up in the Philippines. The only thing they can do is to adapt. And then, sige, cashier, what does it need? What are your requirements to be a cashier anyway? Handle money. Uh, I guess, papasok na lang dun yung mga account managers. They'll be account managers and not cashiers. They'll be managing the accounts that way. That's how they do it here. There's still a few cashiers for miscellaneous stuff, but the bigger bulk is hindi na ganun yun. It doesn't work that way here.
I'll give an anecdote. I'll add on to what Dr. Louis said. This is a similar case. In the automotive industry, halos lahat yan, roboticized. That's a very extreme example of automation. Kasi EHR is a form of automation. Ang nangyari sa kanila, yung mga frontline workers na nawala sa assembly, instead of becoming manual laborers, they went to the different part of the process. They became more of designers, they became more of the CNC programmers, and some of them actually became artisans. If you go to Mercedes, yes, Mercedes, in their production lines, it's all automated, but there are parts of their operations where humans are still there because they're the artisans. They actually design, they put the paint, they screw some ornaments. May part pa rin ng human sa automation. So imagine this: instead of doing mindless work, you're going to where your brain is more needed. Think of it that way. So of course you can't avoid the fact na may mawawala ng trabaho kasi ganun lang talaga sila hinire. But yun nga, there's a sense of adaptation after time. Kasi ganun naman talaga eh. You have to adapt to change or you will not survive. That's the stark reality. And that's part of it. So hopefully the people that are qualified can be put into jobs that their brains are more required for, that their thinking, their analytical skills are more required for. And with blue collar workers, well, maybe you can retrain them, then reassign them. my experience is a lot of nurses actually get reassigned from being, kasi maraming nurses sa Pilipinas. Marami sa kanila nagiging clerks and secretaries kasi in the hospital, kasi sobra yung workforce. Hindi sila, they don't, you can't pay them in the, ano in the floors. So you reassign them. Magiging ganun yung adaptation.
Or you can turn them into nursing informatics professionals.
Yes.
There's
So,
so many of them. So yeah, there's a business proposition for you. Lagay ka ng nursing informatics curriculum somewhere here in the Philippines to train the nurses to get informatics skills. There's one option right now is to go to UP and take the masters in medical informatics. Uh-huh. Yeah, MHI pala, masters in health informatics. You can do that, but well, your problem. Do you need a master's to actually contribute? All right.
so all right. So, no, any more questions, comments?
Hello,
If
Ray.
not,
Question.
Oh,
Yeah, I
oh,
have a question.
yeah,
Dr.
Dr.
Bengson.
Bengson.
Yeah, hi Ray, Mikey Bengson here. Um, you know that I've used two models of an electronic health record for my clinic,
Yes, sir.
and I've had my problems with it. I'm actually looking for another one.
Yes, sir.
So my question is, can I make use of the data that was entered in those two and transport them? How do I transport them into this one? And my second question is if I install this new one onto two computers or more, can they actually synchronize with each other?
Okay. Good question, sir. Thank you very much. First question is about data migration. So because you've used two previous electronic health record software, one is called Clinic Genie, wherein I think you told me that the developer left or nawala yung support. So you moved on to a different one. The current one doesn't allow you to upload any
Correct.
photos or pictures or anything like that. The data migration
Yeah.
part or aspect depends on two things. One is the patient database from the previous software. Uh, Dapat sana they're coded in what we call the XML format. XML. It's extended markup language format. Uh, and it will also depend on the kind of database that was used to store your patients, to store the patient records. So there are different kinds of servers. So right in the OpenMRS, we're using a SQL server, the SQL server. Uh, Somebody has to take a look at how Clinic Genie stored your patient data. Uh, so if compatible siya, you can actually create a script or program something to automatically migrate your old patient data into the new one, the OpenMRS. But if you have a manageable amount of patients on record, you can. I know it's manual, but you can manually have a medical clerk or someone to transcribe everything or to manually input it to OpenMRS. I guess might be the less technical and cheaper way to do it. So that's the data migration part. Or have your legacy software installed in the computer. And if the patient arrives, when your previous patient arrives, load up your old software, and that's when you start a new record in OpenMRS, wherein you
Yeah,
will
that's
migrate.
what we're actually doing already with the new one. As the patients arrive, that's when we just input the diagnosis and other findings
Yes, sir.
manually.
So, yun. For your second question, sir, if OpenMRS, if it's installed in two computers, absolutely they will synchronize. For example, you have a secretary in the front, and you're inside in your inner office where you actually see the patient. Your secretary will have clerk privileges. Your secretary will not see patient data So patient privacy is preserved. You can assign the specific applications that your secretary can do. So you can assign two things. Register the patient's name, the address, phone number, blah blah blah, and you can have them get the vital signs. After she inputs it, she can tag that the patient is ready. That's automatically saved in the server. So hopefully the server can either be the computer of your secretary or in your computer or somewhere hidden. It's up to you. And then when the patient enters your office, you will immediately see the name and the vital signs and all the other notes that your secretary put. That and then your clinical notes will be safe in the eyes, safe, and your clerks and your secretaries will not be able to see what you wrote in your in your patient notes. So yeah, you can. It synchronizes.
I suppose it will also work the same way if I have the program in a computer in one hospital and then the patient follows up in another hospital with the same program.
Yes, sir. Yes.
If I input it in the other hospital, it will. All right, thank you, Raymond.
Yes, sir. It's possible to do that. You'll have to host your server. You'll have to open a port in a network port in the server in the server where OpenMRS is installed and is hosting the database, so that from the internet you can query or you can retrieve their patient data from the server across the internet. So there's some networking issue. There's just some networking things you can do, like a firewall and opening ports. And yes, you'll be able to access it remotely. And people have been doing that in sub-Saharan Africa, in Rwanda, where they deployed OpenMRS in almost all of the rural health centers there. They are all interconnected. And if a patient in Rwanda goes to Uganda or somewhere, the patient data will be there. They will be able to retrieve the latest data from the database. So yeah, sir.
Okay, thanks, Ray.
No problem, sir. There's a OpenMRS community in the Philippines. I hope we can try to contact them. Actually, Jeremy has experience with our Xbox, which is based on OpenMRS. Well, Jeremy,
Thanks.
OpenMRS,
Oh, yung
RX
RX, hi sir, yung RX box is another type of EHR. Parang ano siya, available siya online. You can try it out for free.
James, can you hear me?
You can try it out for free. Tapos pwede kayo bumuo ng sarili niyong records.
Yes,
Raymond?
yes, sir.
Hi, can you hear me?
Yes,
No, this is
Dr.
Ryan
Dalman.
Dalman.
Yes, sir.
Hi, James. I typed a question earlier. I don't know if you saw it. If do you need internet to access OpenMRS?
No, you do not. You do not
So
need.
once you've downloaded it, you can use it already.
Yes, and I can zip my OpenMRS, send it to you. You'll have all the forms that I created, the customizations I created, and you can use it immediately. You just have to install Java 7, and I think
Oh,
it's
okay.
so easy to install that.
And then it's not for example, kunyari, what do you call this, Friendster, something like that.
Yep.
Before it was a big thing, and then naluma, and then nawala na siya. What if that happens to OpenMRS? Kasi it's free, diba?
Okay, yes.
Will that
Good
affect
question.
the data?
A good question. OpenMRS was developed in Regan Street University in Indianapolis. It has the full support of Regan Street Institute, which is academic university in Indiana nga. So when you think about support, if mawalan siya ng support, uh, right now the community is very strong, and it's if you go to the OpenMRS website, which I will load right now, uh, you will see a distribution of OpenMRS in different countries. Here you go. Where are we? So I'll share the picture with you. In three, two, one, and where is it? Here it is. Can you see it?
No, ayun.
Yeah.
Yep. So it's everywhere, even in the United States. So support for it, it's going to be you're going to have really good support for OpenMRS. So kapag if you're thinking malalaos siya, the database, the SQL database or how the patient data is stored in the server is very standard, which means the more they upgrade, they're gonna make sure that your database is compatible pa rin with the newer versions. Yep,
Okay, thank you.
that is a good question. Thank you, Dr. Dolman. So offline to, OpenMRS is offline and can be offline. There's a question by Dr. Lakindano. Is OpenMRS available in handheld devices? Yes, there is a module where you can actually access OpenMRS in a mobile device. Because it's pure HTML, you can access the OpenMRS uh, by just typing in your mobile device browser the OpenMRS URL. So yes, cool, right? You can actually input patient data from your mobile phone or tablet also. So cool. Does that answer your question? Oh,
Yes,
hi.
sir.
We can
Thank
see
you.
a video of them now. I can see Dr. Uy also in the background. Hello.
Raymond.
Yes, sir. Dr.
Yeah,
Bengzon.
regarding Windows, yeah, regarding Windows and iOS, does
Yes,
it make
sir.
any difference where you
No, it
install?
does not. Because the OpenMRS was built in the Java platform. Java is available in both Linux, Windows, and Mac OS X, Mac OS. So it's pretty. It's we call it operating system agnostic. So it doesn't care what operating system you're running, because Java is being used in a lot of websites. Actually, Facebook is using a Java backend. So wala lang. Google Plus using a Java backend. So we're using a pretty uh, Java is used for a lot of HTML or web services. So okay siya.
Okay, thanks.
Yes, sir. So there's no separate installation file for Mac and Linux. It's just the zip file. They just run the jar file, the Java file, the JavaScript file. Okay.
So for all the people here, if you're interested, pwede nyong, I think Raymond can just email Think Tank, then kung sino interested, just contact him or any of the members for a copy. But if you want to play around with it, you can go to the website and download your own copy, put it in your laptop, then mag-trade kayo ng kaklase nyo na, oy, ito, ano, mga forms ko, ganyan.
Yes,
So,
you can do that. Perfect. Yeah.
So parang magko-contest kayo which form is better, ano yung mas maganda, yung mga ganun. Tapos feeling ko kailangan ng form nito o ito ganyan. So you guys can help us in making the program better. That's the beauty about open access. So
Yeah.
yun,
Yep.
parang blog siya.
So yeah, we should
And
include everyone in the process. We're not gonna
yes.
exclude anyone. Everyone should be welcome. Everyone has a say. All the end,
Mm.
you are the end users, which means you should be the our masters. Kayo dapat. Kayo ang gumagamit eh. Kayo dapat magandang gamit niyo.
Actually, may isa pa akong uh, parang job shout out. Kasi malaking problema sa Pilipinas, hindi naman yung software side, it's the hardware side. I'm trying to figure out a way on how to entice clinics, both public and private, to actually upgrade facilities. So if you're interested in brainstorming with me, just talk with me. I'll give you my contact and we can throw ideas at each other on how for everybody else how to make adoption better. So, and to give support. Kasi one of the biggest problems, aside from yung usability, is also the availability of the hardware. Pag ikaw may clinic ka, sometimes sobrang sanay ka na ayaw mo na mag-upgrade. So, we need to overcome that. And imagine mo, in a city of 15 clinics, having 500 patients each in a year, you can already have a pretty good public health idea of what your patients are having. And these are just from private practice. this. So yun yung vision ko for this. It's public and private coming together and the talent working together to solve health problems and uplift our citizenry. So yun, maraming pockets na kailangan magdikit-dikit para masolusyonan. So yun.
Thank you for all the interest that you've given the topic. I propose to Think Tank to do a webinar regularly, like even once a month
Yes.
or once in 2 or 3 months. Any topic, not even medical informatics. Kahit kung sino lang.
Tumatawa si Dr. Shaniel sa likod. So, so yes, we hope this will be a semi-regular thing and we'll be inviting more and more people. It's good that Dr. Rasaniel and some of the residents were here. Next time po, mag-invite pa po tayo ng iba pang mga colleagues natin. Kasi I think it's been very informative for everyone. This is new, this is very interesting. And you can see sparks eh. Nakikita ko yung mga itsura. Iba parang nung may narinig silang interesting, biglang gumanon. Nag-lean forward, parang nag-interview ka lang. So, that for me is a good sign, and we have to start from somewhere. So,
yeah, last point. Just a final word to all the doctors here and all the incoming doctors. The point here is to increase awareness that technology is not going to replace the doctor anytime soon. The technology will never replace doctors. There's always that human interaction that's needed during a healing process. The computer is just there to assist in clinical decision, assist physicians in giving the correct diagnosis and the correct treatment, and to assist public health in this new discoveries and in research. So we won't have an excuse anymore in the future. There's no Philippine data. No, we'll have the data. We'll definitely have the data in electronic format, and we need to inspire researchers and attract researchers to do some clinical research so that they won't get turned off from all the paperwork that we need. They can just do the research in the computer like how it's being done here. And that's what we should do. So if you don't like OpenMRS, it's fine. We've accomplished our goal. Our goal is for you to know that electronic records exist and there are solutions there that exist. If you see something better than OpenMRS, I would praise you for that. And then spread the word. Spread the word to your colleagues that uh, this is the future. We can't be stuck with paper much longer. If you want to progress healthcare delivery and access here in the Philippines, we have to upgrade our minds also. So thank you, everyone. Thank you, Think Tank. So.
Let's give Dr. Uy a big round of applause. Very interesting talk. Then for all the participants, please come forward. We'll have a picture with this giant video in front. So everybody, please come down. We'll have a picture. So thank you again, Dr. Raymond. And
you're welcome. Turn on your video to Dr. Drilon, future Dr. Dalman, Dr. Lacandanum. Yes. Turn on your video para makasama kayo.
Wait, paano yung turn on yung video dito? We'll also improve how we use Google Hangout next time.
So this is the first time, so congratulations.
Yeah, get better. So first webinar in ASMPH. I think this is a pretty good turnout. We're pretty happy that everybody here can join. So yun, di na ako bumay ka. Rinig naman ni Dr. Uy.
Yes, yeah.
Isa pa. Smile. Ready? 1, 2, 3. Okay, thank you everyone.
Thank you for listening. If you have any questions, show me a Facebook message or a Google message anytime.
Ibang consultants na.
Kung gusto nyo ng OpenMRS, I'll send it to you.
I said, okay, I'll make time for this. I'll invite more people. Next time.
I'll invite nga people. I'll try to invite other people from this. I remember some. I got to know.
Thank you, Doc.
Hey, Doc.
Hey, thanks everyone. Hi.
Here.
Bye.
Hey, go to IT. Oi, I know you.
I know you.
Sige, thanks yun. Wait,
Bye.
Oh,
Ang,
30.
wait.
Hey, Raymond.
I thought you were in the States.
Yung gagawin natin.
I came back,
Let's go
but I'm
to-
going again. I'll see you soon.
Let's
Alright,
go.
see you soon too.
Si host natin. Pwede naman sila kasi mag-join online, so they don't need to come here. Oh, diba?
Yeah.
So we don't need to. Ay, yung ay, sorry guys, can you
Thank you.
answer our
Please, feedback
evaluation forms?
We need that for
Bye.
accreditation.
Okay tayo, team.
Thank
Sorry,
you, Doc.
I had
Very much.
too many slides, so I'll try to. It's such a big topic, so.
Informative.
Raymond, ano na lang, alam mo yung mga yung mga did you know na parang dinodrawing lang tapos ginawa nilang video. Gawa tayong spiel na ganun.
Dude, I suck in drawing, so.
yung lecture kasi, I'll link it to you. Maganda siya. It's cute eh.
Okay,
Anyway,
sure.
maganda siyang parang marketing video natin.
Sige.
Okay.
So, yeah, add me on Facebook, Steam, Battle.net, yeah, add me. Kung sino lang. We can play Dota together. Bye-bye.
Talk later about some of the stuff. About the proposal.
Dr. Arsenio, my mentor, thank you. And of course, Timothy.
Okay, anong oras ba dyan? Okay na ba matulog?
It's 7:20 in the morning. See, there's light in the back.
Okay, so
So this is my apartment. Oh, it's so messy. See? Where's the baby? The baby is sleeping. I'll show you a picture real quick before you go offline.
Aww.
To those who are interested. Mhm.
It's yours.
thanks for coming. Next time rin, ha?
So happy.
Awesome.
That's so cute.
Thank you.
Oh, I can be heard from this if you want to.
Kamukha ko naman, di ba?
Yeah.
Okay. Thanks, guys.
Bye-bye.
Hey, success. Outstanding success.